Good evening, everyone. Um, in this video, I wanted to talk about fluvoxamine because this is a drug that we've known about and people have been kind of looking into as a possible COVID treatment for almost a year now. But recently, there has been some good data coming out of the Together trial, which makes it very promising. So I wasn't really looking into this drug until I saw that because there's a lot of drugs that initially look promising, but then when large clinical trials are done, they don't pan out. Um, and so this is one that seems like it might be panning out. So then I thought it was a good time to look into it. So fluvoxamine versus placebo and clinical deterioration. This was Dr. Lenze did a trial back in fall of last year, published it, where they had 152 adults that are outpatients. This is early treatment of cancer, early treatment of COVID, so early intervention at an outpatient basis to try to prevent clinical deterioration. In this setting, you need to have large numbers because most outpatients are going to do well no matter what you do. So this is a small study with 152 people, so the power wasn't great, but they had pretty good results. What they did is they had 150 patients, and there was clinical deterioration in none of the patients that were treated with fluvoxamine, and six that were treated with placebo over 15 days. And this was a clinically significant finding, but it was a very small study. So let's look at this. Clinical deterioration usually occurs during the second week of the illness. Early studies of COVID-19 found that hospitalization most often occurs within days 8 through 10 of initially mild to moderate symptoms. So basically, people start getting symptoms, and within 8 to 10 days, they either get better or they get worse, and they end up going to the hospital if they get worse. If there was something that could be done to prevent people from getting worse, then that would be helpful. However, this drug needs to have very good side effect profile, and it needs to be cheap because you can't treat. There's a lot of people getting COVID. Most of them are going to do well no matter what, and you need to treat a lot of people to help the few that are going to be helped, because most of them would have been fine regardless of the treatment that they got. So fluvoxamine does meet that criteria. It's a very inexpensive drug, and the safety profile is good. Fluvoxamine is originally developed as an antidepressant. It's what's called an SSRI, or selective serotonin reuptake inhibitor. And they believe that the potential that it has some immune modulatory function, and it may stop the excessive inflammatory response that happens with COVID-19, which is the major way that people suffer from. It's not the virus itself that causes the damage, it's our immune system's reaction to the virus that causes it. So they believe that there is a sigma-1 receptor, and it's an endoplasmic reticulum chaperone protein. So the endoplasmic reticulum is a part of the cell that processes proteins after they get synthesized by the cell. They get glycosylated and other things. And so it's a chaperone protein, which means that it shuttles it around, including regulation of cytokine production through its interaction with the endoplasmic reticulum, stress sensor inositol requiring enzyme 1 alpha. So cytokines are a type of protein, and they're thinking that this drug modulates the regulation of cytokine production. Previous studies have shown that fluvoxamine, an SSRI with high affinity for this, reduced damaging aspects of the inflammatory response during sepsis through the. So they studied this during sepsis, which is another condition that people have where their immune system is a little bit out of control. So it is a strong agonist, highly lipophilic. That means it's attracted to fat and has a rapid intracellular uptake. This study tested whether fluvoxamine given as an early treatment with mild disease may prevent clinical deterioration. So it's a double-blind, placebo-controlled, randomized clinical trial. So this is the best study design. So we can't fault them on that study design. And it was done at Washington University in St. Louis. What they did is patients were recruited from April to August. Then they were randomized. They were recruited via electronic records. They did not. They didn't care whether what sex, race, ethnicity, or religion. So they took all those. Then they underwent screening by email and phone, provided informed consent, typically electronically. They were study supplies were delivered as a package left to the door, and then patients self-assessed, like pregnancy, high blood pressure, oxygen saturations. All right, so this is a possible problem with the study. It's hard to know how good the data of these things that were measured were because the patients were doing it themselves. These patients are not medical professionals, but I imagine that they gave them an automatic machine, so there was very little user error that could be introduced, like an O2 sat monitor. It's not hard, you just stick it on your finger. Thermometer, you just put it in your mouth or in your ear, that's fine. Automated blood pressure monitor, I mean, depending on how they used it, you could get false readings that are high or too low if they like held their hand up or down based on the thing. But overall, it looks like it would probably be okay. But that is one confounding factor of this thing. And then dyspnea, shortness of breath, that's a very important measurement. It was measured by a symptomatic scale. Okay, so that's patient, it's not an objective scale, it's a subjective scale. That's another slight problem with the study, probably. So they were randomized and stratified by age. So they try to get the different age groups equally distributed between the two arms. And then they received a dose of 50 milligrams of fluvoxamine, then for 2 days at a dose of 100 milligrams, and then increased the dose to 100 milligrams 3 times a day. Okay, so they were getting 300 milligrams daily for 15 days. They had a ramp-up dose, and then eventually it ramped up to 100 milligrams 3 times a day, so 300 milligrams a day. Okay. After the completion of 15 days of fluvoxamine or placebo, patients were given the option to receive a 6-day open. So at the end of the 15 days, all the patients were given the option to take fluvoxamine, and they knew they were taking fluvoxamine at that point. Before then, they were taking a drug. They didn't know if it was an actual drug, the fluvoxamine, or if it was just a placebo, an inert pill. And so primary endpoint was either dyspnea or hospitalization for shortness, or decrease in oxygen saturation to below 92%. Okay, so those are the primary endpoints. There's a bunch of secondary endpoints, but I'm going to just ignore that. Let's look at the graphs. Oh, where's the graphs? Let's look at the graphs. Okay, baseline characteristics is a fluvoxamine group 80, placebo group 72. Median age looks about the same. Gender distribution is about the same. So there were more women in this study. Ethnicity, race seems to be about the same. Coexisting conditions looks about the same. BMI, so mostly obese people. That kind of tracks with the overall population of the United States at this point, so that seems fine. Okay, so the two studies do not seem different in any of these things that seem to matter. Okay, so clinical deterioration means both criteria. Either they had dyspnea or they had oxygen saturation below 92%. So 0 in the fluvoxamine group and 6 in the placebo group. The p-value was 0.009. Okay, so let's look at the 6 people that had problems. 2 of them weren't that bad. So they had shortness of breath and dyspnea, but they didn't need any oxygen. 3 actually needed to be hospitalized, and 1 of them needed to be ventilated. Okay. So, I mean, if I were to be kind of cynical about this, I would say it's probably like 0 and maybe 4 here, because these two weren't that bad. Well, although O2 set of negative 90 of less than 92 is pretty bad. Okay. Well, depending on how they ran the study, it's their study. They included this metric, but even with this metric, there was 4. So anyway, I think this was a good pilot study. It's a well-designed study. Just their numbers are very low. Um, all right. So there was another study done. This was an observational study on an outpatient basis. What they did is they had 65 people that were, a bunch of people that were exposed to the virus. So they said they read with interest Lenze's double-blind clinical trial. That's the paper we just looked at, and they were like, "This sounds great. We need to check this out too." And so in November to December, a mass outbreak of COVID-19 occurred in an occupational setting with congregate living in a horse racing track in California. So a bunch of people were living together and they all got exposed. We instituted 3 successive rounds of mass testing for SARS-CoV-2, coupled with PCR. After receiving their studies, they were required to isolate per local health protocols. Patients were offered fluvoxamine as an optional therapy. Okay, so this is not a blinded study. People knew they were taking fluvoxamine, so there is it's not a blinded study. So that is kind of a not a great study design. Okay, so they were given 50 milligrams twice daily for 14 days. So that's a much lower dose than in the previous study, which was 100 milligrams 3 times a day. So 65 people opted to take the fluvoxamine, 48% opted not to take the fluvoxamine. So this was not a randomized trial. People self-selected. So it's a non-randomized, non-blinded trial. So pretty, suboptimal study design. And what did they find out? Okay, limitations included the quasi-randomized nature of the comparison. However, anything one would expect confounding. Been treated. Okay, so the subsequent hospitalization was 0% in the 65 with fluvoxamine, 12% in the people that were observed that did not take the fluvoxamine. 2 people required ventilation, 1 died. Okay. So, I mean, this sounds very promising, but this is actually a really kind of a not very well done study. I mean, it's a well done study, but they just they had suboptimal design, non-randomized, and non-blinded study. So open label cohort, real world evidence. So it supports the first study, but these are the kinds of studies that you can't put too much weight on. However, here's the reason that I'm talking about in this paper. Um, on August 6th, the Together trial, which is a great trial that's being done out of Canada and Brazil. They've been testing a lot of different COVID-19 therapies. They evidently presented some very promising results with fluvoxamine. And this is their trial design. They started this trial last year, and the first things they tried were placebo. So it's basically it's an adaptive study. So which means that they do interim analysis, and if things don't seem to work, they knock off the treatments and they try out new treatments. So just like it's a great design for what they're trying to do. So they tried lopinavir and ritonavir and hydroxychloroquine, because these are the drugs that initially, early on in the pandemic, we thought these are the drugs that are going to help us. Well, they did an interim analysis in September and they found out neither one of these worked, so they dropped them. So hydroxychloroquine didn't work, lopinavir didn't work, they dropped them. So then they were checking out fluvoxamine, metformin, and ivermectin and placebo. So metformin did not work, dropped it. Ivermectin showed some promise, so they're continuing to study it. Fluvoxamine showed evidently even better results than ivermectin, so they're continuing to study it. They added on interferon, and doxazocin. So I think that they're going to present the results of this in this video presentation, and they've already published the early treatment with hydroxychloroquine or lopinavir and ritonavir on risk of hospitalization among patients, the together randomized clinical trial. So their main outcomes, the results were, the proportion of patients hospitalized for COVID-19 was 3.7 in the hydroxychloroquine group, 5.7 in the lopinavir group, and 4.8 in the placebo group. So, I mean, it initially looks like, well, 3.7 is better than 4.8, and 5.7 is worse, but they found this was not enough to be statistically significant. So the hazard ratio for hydroxychloroquine was 0.7, but you see the, so you could say that it saved 24% of people from getting hospitalized, but you see the confidence interval is huge. It could be as good as 70%, or it could be as bad as making it twice as bad. It could be construed as being harmful. So anyway, they did this trial and they realized that these aren't helpful interventions, and they dropped them. So tomorrow or the day after, I haven't watched this video yet. I want to watch this presentation with you guys and kind of give any commentary that might be helpful. But supposedly I read that that fluvoxamine was doing quite well. So we'll watch this together in the next day or two. But I think out of all the studies, fluvoxamine seems to be the most promising in a large clinical trial, which is the best kind of evidence that we have.